Assalamualaikum warahmatullahi wabarakatuh. For your preparation, I'll be talking about laryngeal carcinoma. What are the practice pearls that you need to consider? So it goes without saying that comprehensive history and physical examination is very important in assessing patients with laryngeal carcinoma. Generally, they present with a long-standing hoarseness, especially in early glottic disease, but later in advanced stage, they may have these symptoms, for example, dysphagia, stridor, and neck swelling. Vocal demand is very important because it does help in determining the best treatment for the patients, although the patients generally will decide patients with high vocal demand on their occupation or maybe habits or hobbies. They like to sing, they sing in churches and so forth. These are the things that one needs to consider. Risk factors are very important in patients with early glottic carcinoma. Habits such as smoking, alcohol consumption, occupational exposure to petrol, fumes, and so forth may increase the risk of residual or recurrences. Examination of the neck for laryngeal crepitus, for extralaryngeal spread, or a neck metastasis is very important. Laryngeal examination not only focuses on the endoscopic examination to see the airway, to see where the lesion is arising from, but also in assessing or evaluating the patient's function of swallowing, whether the patient has a safe swallow. So you may want to perform a modified FEES in the clinic to ascertain that the patient doesn't have aspiration, because this will point that the patient has a non-functioning larynx, and other treatment modalities which are preserving the larynx shouldn't be considered. Yeah. Cranial nerve examination of the patient's vagus nerve as well as the patient's hypoglossal nerve is important too, and certain factors that affect treatment, for example, patients with trismus, patients with a small jaw, patients with a retrognathic jaw or protruding teeth are very important in evaluating patients who are considered to undergo transoralism microsurgery. So clinic endoscopy is very important to determine the stage of the patient's disease, extent of the tumor, whether we are suspecting extralaryngeal spread, whether the tumor has involved the anterior commissure, because this will then affect the patient's voice post-operatively, and also whether you wish to consider CTs in such patients. Okay, so these are some of the examples of the images of patients with laryngeal carcinoma. You can see here that this patient has an ulcerative mass which has involved both the arytenoid, the airway epiglottic folds, and this mass also has a fungating component which is located at the laryngeal surface of the epiglottis. In this image, you are not able to see the mobility of the vocal folds, and the airway is very constricted. This is another image which is taken using a 70-degree scope. This is enhanced imaging done using the SPICE spectra. In this set of image, you will be able to see that there is a localized mass on the left side of the vocal fold extending throughout its length with hyperkeratosis seen. In this set of video, you are not able to see the full extent of the vocal fold mobility. So if we wish to improve visualization in clinic endoscopy, you may want to consider procedures such as laryngeal gargle. A long atomizer is put so that we can anesthetize the supraglottic by asking the patient to say E. We give lignocaine 10% in order for the lignocaine to reach the vocal fold when the patient is phonating, or even to a certain extent, some of the patients may require not only intranasal, intraoral cofenalkine sprays, but you may want to ask the patient to swallow some lignocaine jelly, or even give some intratracheal anesthesia to anesthetize the larynx to really examine it in the clinic. Yeah. So you don't want to be missing any lesions in patients with high suspicion of laryngeal carcinoma. So the images that we wish to obtain in the clinic are really near images to the larynx in order for us to visualize the laryngeal inlet. So the questions that you need to ask when we are performing clinic endoscopy for patients with laryngeal carcinoma are: number one, is it a unilateral or bilateral disease? Does it involve one vocal fold or does it involve both vocal folds? And if it's bilateral, is it near to each other at the level of the anterior commissure? For example, in this first image here, if you did not perform the endoscopy very near to the vocal fold, you will not be able to appreciate this small lesion seen on the right vocal fold. So in this case, it looks like a bilateral T1B disease. So of course you wish to know whether there is involvement of the supraglottis or the subglottic subside, and this is not possible if, let's say, we are not performing the endoscopy very near to the vocal fold. Mobility of the vocal fold needs to be elicited, whether it is reduced, immobile or fixed, as it determines the staging of the disease. Anterior commissure, it is very important. In this example, the tumor on the right hand side has extended up to the anterior commissure, but as seen here, this tumor stops short at the level of the anterior commissure. Without being near, you won't be able to appreciate the difference between involvement of the anterior commissure. Is it a multifocal, or is it a unifocal disease? Is the extend only here? But in this case, you can see that there is a multifocal mass which is separate from the original tumor. So what are the indications of imaging in patients with laryngeal carcinoma? So here I've listed some indications for imaging in which anterior commissure tumors, when we are unable to visualize the lateral margins, tumors with reduced vocal fold mobility, tumors with posterior extension to the vocal process, or if we suspect extralaryngeal spread or nodal disease on clinical examination, we should proceed with at least a high resolution thin cut computed tomography of the neck. It has to be about 1 millimeter thickness because the larynx is thin. The larynx is generally about 1 centimeter thickness. So if you wish to image it properly using thin sliced CT. In patients where you suspect metastatic disease, it is advisable to have a PET-CT scan in order to characterize further whether is it really metastatic disease, because it's rather uncommon, but the patient may have synchronous tumors in the lungs. Then it's good to have a PET-CT. In cases whereby the extension to the cartilages is ambiguous on CT scan, having a supplementary MRI is very useful in patients. So this paper demonstrates some of the cases in which the CT and MRI results do not actually match with each other. This is the first example in which the patient has an anterior commissure tumor. You can see here from the CT there is no erosion of the thyroid cartilage, and correspondingly the MRI shows similar findings with the pathological results of negative tumor involvement. So this is another example in which the tumor is found to have erosion of the inner cortex of the thyroid cartilage, but this erosion is not seen on the MRI, and true enough, the CT is falsely positive. The pathological results shows no involvement of the perichondrium of the thyroid cartilage with the tumor. So what about paraglottic space? So the tumor is seen here on the left hand side to be involving the paraglottic space. You can see the fat density here, seen on the right side, but it is not seen on the left side. It is seen to be obliterated by this mass here. The corresponding finding is seen on the MRI, and true enough, you can see here on the pathological section that the tumor is seen to involve the paraglottic space. So the ADC sequence MRI has been shown to improve the diagnostic yield in determining the cartilaginous involvement in patients whereby it is ambiguous from the CT scan finding whether there is erosion of the cartilage, because this is very important in clinical staging of the patient. So operative evaluation is, I think, the most superior tool for us to determine whether the extension of the tumor is seen. So you may go to my video later. I'll just show some pertinent findings. We're running out of time. So here you can see when we are cutting the margins of the tumor, if let's say there's excessive charring using the laser, you will know that we have actually cut through tumor. So in this example, there is no charring seen, and you can see that the tissues are separating so nicely. As we go along, similarly, we will determine the extension of the tumor by seeing the charring as well as seeing the tumor by direct vision with magnification, and this will help us in determining the three-dimensional extent of the tumor. And I think the operative evaluation using a telescope, 0 degrees Hopkins telescope, an angled scope, 30 degrees scope, see carefully the undersurface of the vocal folds, and when you're cutting, as you're cutting, you're seeing the extension of the tumor. This is actually the gold standard of the tumor extent. So surveillance visits, what do you expect to see on surveillance visit? Okay, in the early postoperative period, sometimes it is very difficult to determine whether the patient has a residual disease. This is because sometimes you are clouded by the presence of granulation tissue. For example, you can see here on the right hand side, the patient has a small mass over the vocal process of the arytenoid on the right hand side. You ask yourself whether is this tumor or not. Yeah? So, secondly, the patient may have some funny compensatory mechanism. For example, seen in this case, in which the patient has anteroposterior constriction, causing the arytenoid to rub against the laryngeal surface of the epiglottis. And you may wonder whether is this tumor or not. Sometimes you may want to use enhanced imaging or even look at the original pathological reports of the patient to determine whether is this really a residual disease or not. Okay, one would like to aim to see evidence of scarring, in the clinic. This is what is expected after a transoral laser microsurgery. For recurrent disease, it is easier to be ascertained by the presence of new symptoms and new signs. Hoarseness now become a less reliable symptom. This is because after any intervention to the larynx, be it radiotherapy, transoral laser microsurgery, or partial laryngectomy, the larynx is bound to have some scarring at the vocal folds, and this scar will cause the patient to have hoarseness, and therefore hoarseness becomes a less reliable symptom. We are looking for new symptoms, for example, new neck swelling. Here you can see that there is a swelling at the anterior part of the neck superior to the stoma in a laryngectomized patient, or sometimes swelling adjacent to the stoma at the clavicular head. This may represent stoma recurrence or residuals. Then we are looking for new signs, for example, in the vocal fold mobility. This patient is seen 6 weeks after transoral laser microsurgery for early glottic carcinoma. The vocal fold was mobile before, and here you can see that now the vocal fold on the left hand side is fixed, and there is an ulcerative mass seen on the left vocal fold. Another new sign in this patient was seen 2 years after radiotherapy, and his complaint was for radiotherapy for early glottic carcinoma, and his complaint was he was unable to hold his breath for more than 2 minutes, and with intratracheal anesthesia given, one will be able to see that underneath a nice and pristine vocal fold, there is a subglottic tumor which is extending down to the trachea. So we must not disregard any new signs in patients with glottic carcinoma who has received treatment. Yeah? Keep in mind these patients will have scarring, and you are looking for a bulge suggestive of a new tumor. So think, in summary, clinical evaluation focuses on functionality aspects of the larynx, staging and treatment related factors, and select patients require imaging, mainly thin sliced CT neck, and operative evaluation remains key to management of these patients, especially in patients treated with transoral laser microsurgery. Thank you.